Welcome to End of Life University on YouTube. Today I'm sharing with you a conversation I had with Dr. Kimberly Curseen. Dr. Curseen is a palliative care physician who writes and teaches about implicit bias in end of life care, and that's what our conversation focuses on today. It's an important topic and very interesting. She has so much great information to share, so take a listen. If you enjoy this kind of content, be sure and tell other people about the channel and let them know how to listen in themselves. If you haven't already, subscribe down below, and also subscribe and leave a rating and review for the podcast wherever you happen to listen. In addition, if you're willing to pitch in a couple of dollars here and there to help support this show financially, you can go to eoluniversity.com/support. And there are 3 different ways you can make a contribution to keep us on the air. So we'll move on now with my interview with Dr. Kimberly Curseen. Today, I'm so very happy to welcome my special guest, Dr. Kimberly Curseen. Dr. Curseen is the Director of Supportive and Palliative Care Outpatient Services for Emory Healthcare and serves as the Director and the primary provider for the Supportive Oncology Clinic at Winship Cancer Institute. Board certified in internal medicine, geriatrics, and palliative care, she is part of the clinical care team providing physical, emotional, and spiritual care for patients with cancer at any point in their disease process and assisting patients with complex decision making. Prior to joining Emory, Dr. Curseen served as the program developer and director of Geriatric Palliative Care Clinical Services Program at the University of Arkansas. So, Dr. Curseen, welcome and thank you so much for joining me.
Thank you for having me.
Well, today we'll get into our topic matter, but usually at the beginning of all of my podcasts, I like to ask my guests a little bit about their own story. If you would share with us what attracted you to the field of palliative medicine, because not everyone chooses that when they go through medical training.
No, that's always that's a great question. I think it's a little bit of a roundabout story, so I'll try to make it as short as I can. My very first day as an intern, I started in the ICU, and it happened to be a very busy night, and my resident was really preoccupied. So I was in the ICU by myself, and a patient's son came up to me and said, "I don't think I want to do this anymore." And I looked at the nurse and she shook her head yes. And I said, "Okay." And we talked a little bit about his reasons why. And then he says, I think it's time to remove these things from my father. And I looked at the nurse again and I was like, "I guess we can do that." And she's like, "Yeah." And I said, "Okay." Um, and I remember, being in the room with the respiratory therapist. The nurses took great care of me. They told me exactly what to do. And I don't think I really had a clear concept of what was happening or that this wasn't normal. And his son was crying and very, very distressed. And I remember saying, "You are a very good son." And the look on his face after saying, me saying something I was hoping that was going to comfort him, and I assumed that would be true, had a really profound effect in that moment. And because the nurses in the ICU were really great and told me what to do and knew how to keep somebody comfortable, everything went beautifully. Now I know it went beautifully. I didn't know at the time. And that was sort of my first entry. And I didn't have, when I talked to other people, I didn't have the angst that some of my colleagues kind of had about it. I did have to explain it to my attending who didn't quite understand why I didn't call him. But that was just sort of, and it wasn't so much the person's death, but it was, being able to have the knowledge to be able to let somebody know that this was, number one, it was okay. it was going to be okay, and that they weren't alone in that decision. So that sort of started, I think, my journey, although I still didn't know palliative care existed. Went through residency and became sort of the resident that if other residents were having difficulties, or if there were families that were really struggling, they would say, can you go and take them on your service? I think, they would respond to you a little better. I didn't think anything abnormal about that. And then after I finished residency, as I was starting to finish and thinking about what I was going to do with my life, I went to my advisor, who, he was great, and my advisor the whole way through. And I asked him, I said, hey, I was looking online, I found this thing. I was wanting to be a geriatrician, but wasn't sure. And I found this thing called, palliative care. Maybe, and I said to him, maybe I could do that. And he looked at me and said, oh, Kimberly, you can't make a career out of that. And I said, okay. I didn't have, any kind of frame and any reference frame. So long story short, and because of my life circumstances or responsibilities, I needed to be a hospitalist to make money for my family and all of that. And I moved to North Carolina, became a hospitalist. And then the same thing started to happen again with the patients. And they asked me to be a hospice medical director. And because I never say no to anything, I said, sure. And then so I went to a hospice IDT, and they were talking about giving people morphine in the home, and I was horrified. It's like, what are you doing? I said, I probably should figure out exactly what I'm doing here. And that was the life-changing experience. Those hospice nurses at Cabarrus Hospice in Concord, North Carolina, put me in a car, and as they would say, they learned me something. And I learned. And I got to see people through all walks of life and go into people's homes and really learn what it meant. Like, why were my patients coming back and forth to the hospital? Why were these things happening? And it just opened my mind to kind of what transitions of care meant, what it meant to have dignity, what it meant to have goals. It led me to ask a patient that I had that I adored a lot, about, as a hospitalist, she was coming back and forth, and I asked her, what is it that you really want? Not in a palliative way, probably in a non-palliative way. And she said she wanted to go to the beach. And I was like, okay, well, let's make you so you can go to the beach. And we were able to do that. So that was sort of my first thought, and having that experience led me to open my mind to what was possible for people. And then from there, as all things happen, I met a guy, I moved to Arkansas, and was fortunate enough at that time I could pursue a fellowship in geriatrics, and then stayed for second year to do a concentration in palliative care, because I didn't have fellowships back then. And once again, I saw this deficit where we had everything for cancer, but there was nothing for the other illnesses that people were passing away from. And particularly being in Arkansas, there was a big, divide, financially. So that kind of led me to develop a geriatric palliative care program. But the fortunate part, and I can't believe they let me do this, I got to see patients in the home. I developed a clinic, home-based care, nursing home, and assisted living. And that was an education. And I was able to spend time really practicing in all of those environments. And I got to understand not only, what was happening with patients and what their goals were, but what were the barriers to the care they could receive. So, and as we were providing, as I saw, we were providing, end-of-life care to patients, and we were, talking with patients about their goals. And I remember often sitting there thinking, I know you're asking them what they want, but I'm not sure they can have any of those things. And realizing that my colleagues didn't really understand. They knew to ask what they wanted. They knew, that part, but had no concept of what it was like to sort of pull that off, what it took. So circling all around, I spend a lot of time in that area trying to take what a person wants and make it as close as an approximation. And then also spending time, talking to people that they may not necessarily get what they were hoping for. And again, my husband was able to be nominated as a judge in Georgia, and so we moved here, and I got a job. Tammy Quest, who's famous in our world, was nice enough to give me a job, and the job that was available was to develop an outpatient clinic. And as usual, I said okay, and developed a clinic that started around 80 patients, and developed. Now we do about 3,000 visits a year. And we started seeing, because my background wasn't cancer, I was very comfortable with seeing people very upstream and figuring out how do you manage symptoms when people are just starting or in the middle or sort of living with chronic and serious illness, where we know that their time isn't in months, but the time is in years, but they're going to need help and palliation and all of that transition of care, all of those lessons from the community, all of those financial lessons, the times I was humbled, those patient stories, my own personal background, really helped in devising my true north about how we practice palliative care. So that's it was a lot longer than I thought. But
No, but that's perfect, because I was going to ask you anyway about your work in Arkansas. And so you brought that in beautifully. But I know you mentioned the barriers, to patients getting what they want or having what they might want at the end of life. And one of the things I wanted to talk with you about today that I know you've written about is implicit bias in our healthcare system, which becomes a barrier for patients getting the care that they need. And so first, I thought we should start by defining implicit bias so everyone listening will understand what we're talking about.
implicit bias is the unconscious biases that we have that we're not aware of, and they come from how we were socialized in society. So we may, whether or not how we react to people who are different than us, and often the underlying undercurrent of why we do some of the things we do. But these are biases that we're not aware of. They're instinctual. They happen before. And then explicit bias is, the biases that we show. It's just like it says, the biases that we show outwardly. So the implicit biases that we have, that's malleable with exposure and time and learning. Once you become aware of the biases that you have, you're able to change those, even though they're instinctual. You're able to modify or mitigate the effects of that. How it manifests itself in the healthcare system, I sort of think about our biases as kind of like the bedrock or the foundation that a lot of our structures are built on, whether implicit or explicit. And that on top of that foundation has allowed us to build systems that disadvantage minoritized groups, disadvantage women, disadvantage people with disabilities. And the system is made in a way that puts these structural barriers and, such as structural racism, racist policies, discriminatory policies. And why we accept them and why we build them is because of the way we think about them. We don't, we talk about structural racism or by, the things that the systems, but the systems are made by people, and the people are socialized in a way that causes them to reinforce or act upon their biases and their worst and some of their worst instincts. So the ability for us to, number one, be very self-aware, to recognize our biases, is incredibly helpful. But that awareness has to translate into action. But the structures are the things that we have made. And we often talk about the structures or the barriers as if they're insurmountable. But we created those barriers, and we created a system to serve ourselves. So we are very capable of altering that system.
I know I've read lots of studies over the last couple of years pointing out the racial and ethnic disparities in care at the end of life, which we know are there. And it concerns me sometimes when I see even hospice organizations and their focus is let's enroll more diverse patients. That's the main focus. To me, that is the symptom, though, of an underlying issue. And we can't really fix things by simply focusing on the symptom and trying to bring in more patients. We have to understand what's wrong with the system and how do I contribute to the problem in the system without even knowing it.
Yeah, you're absolutely right. It's very interesting. Like if you were running a business and you sold vegetables, and then you sold the best, most wonderful vegetables that anyone's ever seen. But the community that you live in are on paleo diets, and they come into your store and they ask for meat. And do you say to them, oh, well, please eat these vegetables. We're not going to sell you meat. And you know what, you're completely uninformed. No, you would change what you're selling to fit the population. But in hospice and sometimes in palliative care, we don't do that. So we've developed the structure, and the structure is, it's a lovely structure, but it's not a structure that fits, the lives of all people. It's still very much based in normative kind of Anglo-Saxon views and values. And it has served many, many people of diverse backgrounds. But when you're with a population and it's not serving, then the population the problem, or is what you are offering them the problem? Any other thing that you give to somebody, if they don't like it, you change it for them. But in this particular case, we demand that people bend to us in order to get the services that they need. And when they don't bend, then we say that clearly they're uneducated, and if they just understood more, they would bend. So we put the blame and the burden on the minoritized population, and then we also pathologize. Then if you don't want it, clearly there's something wrong with you. We have to figure out how to enroll more diverse patients. Well, the underlying current of that is that there's something wrong with these patients. And we have to figure out how to get them into our hospice versus thinking about, is what we have to offer going to serve the community? Is it going to fit within their values? And so I think there's a revolution going on, and I think we in our field where we're thinking about that more, we're being more conscious about that, and we're starting to talk about that. But I love my field. This is my heart and soul, but it is very us-centric. It is very doctor-centric. It's very, very majority normative centric, and it doesn't always leave room for other thoughts. And I think that's kind of hard to hear, because we're supposed to be the people who listen and talk. You can read any like any research paper that comes out to talk about minorities and minoritized communities, and whether or not they have goals of care discussions, whether or not what they think about the end of life, or all just, you don't even have to, you can read the title, you always know what the conclusion is. The conclusion is always, you need to talk to the patient and figure out what their goals and values are. Oh, well, some patients in minoritized communities feel this way, but not all. So you need to listen to what their goals and values are. So you just got several millions of dollars in a grant that told you to talk to your patients. That is actually our job. Like, if you're not doing that, what are you doing when you walk into the room? And if you feel like you need to develop a rubric, like before I go and talk to you, now I have to figure out and develop a rubric of how I actually talk to you. Well, you should be culturally aware. You should have an understanding of history, because that will help you understand the answers I'm giving you. But I'm a human, so you come and you can talk to me. And then once I tell you, then accept the answer that I am giving you, and then figure out how to deliver the palliative care within the value system, because you told me that this was about me. So.
Mm. That's such a good point. So well said. And it brings up another term that you've written about, which is cultural humility as opposed to cultural competency. And it made me recall, 10 or 15 years ago, sitting in a clinic, attending cultural competency training every quarter, and remembering, like, our clinic, even in a small rural area, was fairly diverse. We had patients from that represented 11 different cultures. And I remember sitting there thinking, how am I going to become competent in 11 different cultures in 1 hour a quarter? I remember just not quite understanding what that training was about. And when I first read what you've written about cultural humility, that explained it all to me. So please talk about that.
And so cultural humility is basically when you are going to talk to someone, you are leaving yourself open to have your assumptions challenged. You are allowing them to present how they view their culture to you. And you are accepting of that. So the reason why that's important is because even if people, I always say I'm Catholic, and there's going to be differences if whether I'm Jesuit or whether I belong to another sect in the Catholic Church. And although we're all Catholic, we may hear the doctrine differently, and that will have us draw similar but possibly slightly different conclusions. So if you just stop at knowing that I'm Catholic, there is very a possibility that even if you do the list of things that you learned in your cultural competency class, you could possibly miss the point. And if you're not sure, and then you go further from cultural humility into individuation, even if I tell you, even if I'm very explicit about what my culture is, how my culture functions, you still don't know anything about me, really. Now you have to ask me, okay, Kim, do you ascribe to any of that? So you identify yourself as Catholic. Now I know what church you attend. Is that important to you? Do you follow all of that? And there's a possibility I don't, even though I just gave you this long explanation, of my faith. So it's when the ability to, you not only have to let people tell you about their surroundings and themselves, but you also have to let them tell you how they see themselves and how they plug in. And that's a deeper approach, and that's when you get there. But what I would say about cultural competency, that we don't throw it out, because like if you go to France, right, you get a guidebook, right? It tells you all the major things, right? So you have a sense of understanding, you have some French words, You wouldn't just, go to a foreign country with no guidebook. So think of your cultural competence as a guidebook. You would never walk into a patient's room that had multiple myeloma and not know anything about multiple myeloma. That would be insane. So, but when you walk into the room, you're bringing your knowledge of multiple myeloma. So as they are talking to you, you will understand a working knowledge of what they're saying. Right. And then, even though I know multiple myeloma can cause terrible bone pain, I don't go to the patient if I ask them, do you have pain? No, I'm nauseated. No, that can't be true. You have multiple myeloma. You must have pain. Well, no, you don't. You don't. And it wasn't, so it's not that your knowledge failed you. You needed that knowledge, but you were able to say, okay, he has this diagnosis. How interesting that he doesn't have pain. I'm going to go ahead and treat his nausea, but I will keep in the back of my mind that if he has pain, it might be secondary to his bones. So you actually need all of it. And the truth is, most people, if you are showing a genuine interest and you have made the effort, even if you make a mistake that's inappropriate or do something culturally inappropriate, they're apt to forgive you and give you gentle correction. Most the bargain basement thing that people want is respect. They don't expect you to be perfect or to know everything. But what they need from you is to be authentic and curious about them and respect them and take what they're telling you, accept what they're telling you, as valid.
And I can understand it sometimes in our healthcare training, in our delivery system in healthcare, we rely on protocols and standardization of care, which goes to in the opposite direction of cultural humility, because it may, as a time-saving mechanism, it may push some providers to think, well, I have this quick review of systems. I'll check these boxes off. I'll just ask these questions, and they may fail to ask actually the most important questions they could ask. And it's really sometimes not even asking the questions, it's more listening to what the patient wants to tell you.
Yeah, absolutely. And we do worry that it'll go on too long, or we won't be able to get to the day or the visit, and from the provider and from the doctor's side, or from the advanced practice provider side, those are valid issues. But when I'm working with residents or fellows and the patient tells this story, they come in with a very complicated history and they tell their story. When I'm quiet, they tell me exactly what's wrong. They usually go through the differential, and at the end, I almost always have a sense of what I can do about it and what's most important. Right, just asking those questions. And I moved away from. I do ask, what are your hopes and what your goals are, but I always start with, what is it that you need? What is the need? Because I can't deal with your goals until I deal with your need. If your need is, if I got your needs covered, then we can be aspirational. But, what is it that you need? What do you think would make it better? How much is this affecting your life? Those kinds of questions to get at, not only what they told you, but is it something that you need to address? Is it something that you wanted me to listen to? Is it something that you wanted me to learn about? When you interrupt people, you just start all over again. So now they're not satisfied. You don't have the right information, and you order 45,000 tests. When if you just listen, they would have told you. They would tell you. It kind of, and the power. One of the beautiful things about our training in palliative care is that beautiful power of being able to sit in silence and being able to allow people to fully express themselves and get their thoughts out, and that intense listening is incredibly important.
Absolutely. I wish every doctor could get that training in every specialty because I think it would really change our healthcare system for the better.
Mhm. Yeah, I think so. I think so. It would cut down a lot of the frustration and probably a lot of the tests.
Yeah. Well, I know I read in your bio that you worked in rural Arkansas. I guess that was part of your fellowship training, and that you work to educate community members and healthcare providers on implicit bias
Mhm.
and cultural humility in healthcare. So I was curious about that work and what did you learn there? What were your takeaways from doing that work in Arkansas?
Um, and in Arkansas, when I was there, I did that and also did a lot of education for geriatric principles in geriatric palliative care principles. Um, and what I learned of very humbling, that even though people could hold views that were difficult, when you are, it is different than when you are with a person one-on-one. That I learned that people could even still be very affectionate and kind of hold, me in regard, at the same time hold views of bias and bigotry, and 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 it allowed me to sort of learn that people just aren't one thing. They're just not one thing. And so um and that has been helpful because the profession that we chose, in your professional life, it didn't, nothing ever said that it was palliative care for like super awesome people that did, that were wonderful. You get health care because you have a right to it because you exist. Your humanity, you being here in the world is enough for us to be able to care for you. And it's not based on what you do, it's just based on because you are here and the value that we kind of place on life. So it took me, one of the lessons I learned was sort of how to live in that duality, how to still do my job, but also still hold true to my values. The other thing, a lot of the things I learned were people know, they have a great sense, and there's a lot of wisdom in our communities. When they come to us, they have, ideas, people know when they're not doing well. People know, have a sense sometimes when they're dying, not always. Um, but we are obsessed with making people say it.
Mm.
Like we are obsessed with that. Like I remember I had this really wonderful patient and they said, they were gonna they know everything. I want my life to be saved. Just shut down any what we call those goals of care conversations. So as things were getting worse, and everybody was worried, I said, well, maybe I'll just try this. I think we're not going to do any more blood transfusion. Patient goes, okay. Then asking other questions.
Mm.
What do you want? I want everything. Okay. Everything that's going to make me better. Okay. Well, it's not going to make you better. I think I think you've been telling me that you've been missing home. So I think I'm going to go ahead and order hospice, and they're going to come out to your house, change your rooms, and, kind of went through all the things practically, and talk about just these people. This is an insurance benefit, and they're going to come and do this stuff for you. So you don't have to, keep staying here. Okay. Accepted it. Up into the very moment, he never said, and each time we checked in, is this okay? Do you understand? This is why I'm doing it. Not holding anything back, but he allowed me to do all of those things. But I didn't need to challenge and have the big moment that I think we're all looking for, where somebody bears their soul to you and tells you, that it's okay, and, and that they've come to the realization. Because, sometimes I wonder, when we're asking people to do that, or do they have prognostic awareness and we have to see it, are we doing that for them, or are we doing that for us? And sometimes what I tell fellows is like, look, if you go and you undo somebody, if you put, you untie those threads, that is an incredibly powerful moment for you. It's an incredibly powerful moment for them. But you are going to leave and go get it with your healthy body and get into your car and go do whatever you do, live your life. That person is going to sit with that. And then that person might have to go, after having that emotional experience, particularly like if they're in clinic, they may have to go back to work. They may have to go pick up their kid. Life still has to trudge on. And if they give you the privilege of sort of bearing their soul, then you really need to be there, because now you have created this bond, and when things are wrong, they're going to call you. They're going to need that kind of security, because you're the one that untied everything. So, so sometimes people don't always tell us, or they're stoic, or it's not for not knowing, but to admit that, when we ask those questions, we ask it in our time. We don't ask it on their time. We ask it in our clinic. We ask it at our hospice visit. We ask it when we walk in the room, at a time of our choosing, not a time of their choosing, without a thought as to what it's going to be like after we leave.
That is such a good point, and it really brings to mind, I have a friend right now with glioblastoma, who she told me the social worker from the palliative care clinic calls her every now and then to say, is there anything you want to talk about? And she said, I know she wants me to say that I want to talk about death, but I don't want to. I'm not ready to. I don't want to go there. So I just say, nope, I'm fine. And I hang up. And but I realize, like, everyone has their own time frame for when they're ready to become that vulnerable, and to really look at that. And maybe it's not until the last couple of hours of life. I don't know. We have to respect that, though, for each patient.
Yeah. Yeah. People, the patient I was talking about before, they allowed us to do everything that was practical to do. And trusted that we understood what he had asked us for. So if things were that we could do that may seem more aggressive, we did those. The things that had absolutely no benefit or wasn't going to extend his physical life, we did not do. And that was the deal, and that ended up being okay. We think about, in our profession, the idea of dying at home, and a lot of people have been writing about this, that maybe that's not the best thing, because at home it's not great. And I'm so happy to see that. I think one of the things that have always distressed me, and I think, everybody has moral injury in their profession, but I think one of the things that was really, I really struggled with, was the idea of concurrent care. Because, when you think about healthcare disparities, it's always people of color, want more aggressive treatment. They don't want to give up this. They don't want to give up that. They're not enrolling in a hospice. Okay. That's what they're saying. And that's what I was learned. That's what I was taught. And then one day I read this beautiful CAPSI article written, and I can't remember the doctor's name, about VA when they started the concurrent care program. And they wrote how terrible it is that we make patients choose this terrible choice, that they could have this and that. And so I'm like, well, this is okay, but when people of color do it, there's something wrong with us and we need more education. But when you do it over here, it's concurrent care and they're being forced to make a terrible choice. So I think a lot of the barriers that people face is not only and when you bring it back to implicit bias, not only are the structures not set up in a way that produces equity or even justice, but even the way we think about our patients and people have been infected with such bias of our own making that it prevents, even if we tore down the structures, I'm not even sure if we would behave differently.
Mhm.
So I see a lot of movement and change in our field now, starting to reconcile and reckon with this, but it is going to be a struggle, and trying to figure out how to change systems and structures and policies is a heavy lift and will require our profession to maybe shift and change and maybe even lose some things.
And I know one of the tropes that I've always been taught is that people of color don't trust the healthcare system and therefore don't necessarily trust hospice. But I've read what you've written, that the studies don't actually bear that out, and that's something that we believe, and so we operate from that belief. But that's another one of those assumptions that we've made without actually being culturally humble and asking about it or finding out if that's the case.
Absolutely. I think when you ask, it's depending on how you ask the question. So do I trust you? Sometimes we equate trust with doing what you want me to do. So of course, yeah, I trust you. I trust that you believe that this is the right choice for me. I even trust that you have my best interest at heart. It's not that I don't trust you. I just don't want to do that. I want to do something else. So I think sometimes we think about trust. Is there distrust in communities of color? Of course there is. And, if you really think about it, it's actually a little insane there's not more. I mean, if you think about the history of medicine in this country, um, from, our father of OBGYN that mutilated Black women, um, you know, classifications that, to prove our inferiority, surgeries and the mutilation of our bodies over and over and over again. Everybody kind of thinks Tuskegee, they talk about, oh, Tuskegee happened and that, but it was long before then. Over and over and over again, each time, trust us, trust us, trust us. And over again, it didn't bear out. It didn't bear out. We were let down. And so now when we walk in, oh, well, we know all this bad stuff happened and all these things happened, but no, you can actually trust us now. And believe it or not, a lot of us, despite that long history, that if you really read it, yeah, no, there's no way in heaven we should even bother to trust. We still do. We still do. But trust doesn't mean, that I am blind obedience. And that's what we are frustrated with. It's the question. Because it was the question, well, is there another way? Well, could you do this for him? Well, why can't he have that? And the frustration we have is sometimes we don't actually have the answer as to why.
Mm.
I want to bring I'll bring him home on hospice, but I want him to continue to get his TPN. But we don't do that. Well, why? They're being difficult. They want everything. They don't understand. Well, no, they understand perfect. They're accepting hospice, so they accept that their loved one's going to die. But they want TPN a little longer. You don't actually have a good reason other than financial, and you could probably just say that and they would understand it. But you know, we have to, a lot of the way, in order to sort of change, besides tearing down the structure, when you think about it on a person-to-person level, we have to get to a place where we're seen as fully human. Like, if, how would you want to be treated? Would you accept this? And if you would not, then why would you expect me to accept it?
That's so true. And again, speaks to not making assumptions about people and just listening and having respect for people's choices or people's wishes, which is what we claim we do operate with, that kind of respect.
Yeah.
But it's just so important. But I have a real concern also about the disparities I read about in pain management,
Mhm.
which I think that has to be coming from implicit and perhaps explicit bias, the
Absolutely.
pain management discrepancies that we're seeing in studies.
Yeah, absolutely. Yeah, everybody quotes, the study where, medical students thought African American people didn't feel as much pain. Um, when back in the 80s, when the days of super predators, when people thought of kind of drug use, it was a criminal problem. When it was, primarily, or we thought primarily were affecting minority communities. So that was the focus. And, had a war on drugs and all of these. Now that it's affecting the wider community and the majority, then all of a sudden it's a public health crisis, and we must address it. If you are socialized to believe that people of color are, more dangerous, more apt to use drugs, everything is telling you this, from, the TV screens, from the things you hear, from even as little children. These are the things that are planted in your head. We don't wake up one morning and decide to be like this. We are we are inundated with these images, and not just, white people, Black people, all of us are inundated with these images. So we all probably have some form of bias in this area. So if you are not aware of that, or if there are not structures in place, when I come in and maybe I'm, not, I'm dressed okay, but maybe a little off, and, maybe I have a different hairstyle, my nails are a little bit too long, and I come in and tell you I have pain, all bells and whistles go off. You don't even know why bells and whistles go off. You become suspicious, scared. Maybe my pain's not that bad, right? If I'm well dressed and well spoken, young, white, and I come in and say, "Oh, I have terrible pain," the reaction is different. And to prove it, patients actually talk about, there's actually like, oh, how to get pain medication out of your doctor. And that is a sense of, that's how we were socialized. The way to address that is, we're not going to be able to rely on our natural instincts in this case, right? So for some things, you rely on, what you think and what you feel. We can't do that here. Here, we have to rely on things that are more concrete. This is where process helps. This is where, because if you're asking the same question and you have a standard of how you usually manage things, and you follow that process over time, I have seen over time that people develop empathy. They start to listen, they start to ask, because it challenges the assumption. Like, I'm nervous, I don't want to give this, but he's hitting all the check boxes. I don't have any history. and you get the medication because it's based on, based on the criteria that were set. It helps if we are all self-aware and if we are aware of our biases, but not everybody's going to do that. And you have to want to do that. You have to be in the position to do that. So in this case, we can't just be left up to our own devices. We have to put in guardrails that have us practice to a standard. And not only protects minoritized communities from underprescribing, that helps the majority community not to be overprescribed. Right? And this doesn't happen just with people of color. This happens with women. Young women comes and complains of pain, especially abdominal pain. And it's not obvious what the diagnosis is. More than likely, oftentimes might be either seen as hysterical or a drug seeking or dramatic, and without getting the proper workup, because that's the way we're socialized. So not everything has to be a process and be rigid, because that would not be good. But we do have to put some standards in that force us to ask the questions that we are supposed to ask people each time that would lead us to the correct answer, versus just leaving us to our own devices.
And I'm wondering if you have thoughts about how each one of us, and even people listening, can become more aware of their own implicit bias. Because I realize if you just go up to someone and say, "Do you have hidden biases?" everyone would say, "No, I don't," because we're simply just not self-aware. We're not reflective enough to be able to see those. But it's so essential that we be able to really look at ourselves. And I'm just wondering, does it help if we pay attention to like the thoughts that come in our head when a certain patient walks in, or we see someone, the thoughts that arise, and examine those, like, wow, why am I having a thought like that about this patient? But any tips that you have for us?
That's actually the perfect, and that you said that so beautifully. There is the Harvard implicit bias test that could actually show you, your biases. And I say, if you take that, really just be in the right frame of mind, that it's not passing a judgment. It's just saying this is what it is, and this is what you can choose to mitigate. When you're in clinical practice, I would sometimes say, particularly in Arkansas, when I got to spend more time with our fellows, sometimes we were going to go in the room and I would say, "You can't go in the room." And they would be frustrated with me because I'm making rounds long. And I would say, "No, because you have to fix your face and get your mind right." And they were like, "What are you talking about?" I said, "I can see it on you." Patients, people don't remember 20%. Just a fraction of what you say. In this podcast, and people listen to it, they're going to remember maybe a few words, but they're going to know what will stick with them is how I made them feel. That's what'll stick with them. So when you walk into a room with a patient, they are nervous and scared, and it's all of these emotions, and they are scanning you, trying to figure out, is this friend or foe? Is this somebody I can trust or not? So if you walk into the room tense and frightened, and that's what you show, then you leave nothing but for the patient to mirror back to you that. So sometimes the things that we think that we're seeing, we're really good as human beings as saying, somebody's like this. And then we have an encounter and we do all the things that will push them to do the thing that we were upset about, and say, "Oh, see, I knew you were like that all along." Well, I wouldn't have been if you hadn't done all these things. And we do that a lot in healthcare. Provider comes in and maybe there's a family member that's non-English speaking, or maybe it's a really large family and they're very nervous, and they walk in and they're nervous, and the family's like, "Well, they're scared. I'm scared too. Maybe we should all be scared." So I try to explain that you are the temperature. So if you have a person that you are talking to and something in their history triggers you, if you don't want to go in the room, if you're tense, take a minute, because they're going to still be there. Take a deep breath and figure out why. Is it them or is it you? And once you have that settled in your mind, then that allows you to then use your deliberate behaviors and follow the steps. And maybe you don't feel the empathy, but you will still do the proper things because you are kind of aware of that. One physical trick I tell people is that when you are in a family meeting and you're really nervous about it, I say, sit down and put your hands like under your legs. And I want you to lean forward. So, and you feel the pressure on your hands as they're talking. Now, when they say things that you don't like, you're going to lean back and you're going to feel the pressure release. When you feel the pressure release, you know that you are disengaging. What you're giving off is not, you're moving away from them. So now what I want you to do, is uncomfortable as it is concentrate on keeping that constant pressure. And that also lets you know where your triggers are. So you can remain self-aware. What are the things that they're saying that's making it difficult for you? So, and none of this is easy because we're all human beings and we're all going to mess it up and fail. We know we will, and people will forgive us, including our patients. But the most important thing, I think, is that we continue to strive to be better and strive to live up to our ideals.
I really love that. Pause for a moment and fix your face and fix your feelings. Like that's something memorable that I'll never forget because it's just so true. Before you're walking into any sort of interaction with another person, do that self-assessment. Like what's coming through in my energy or my facial expression, and what are my feelings right now? And can I quickly assess those? And as you said, at least even being aware that I'm feeling all this emotion, I may not be able to get rid of the emotion or make it subside, but the very fact that I'm aware of it will keep me from unconsciously letting the emotion dictate my behavior.
Yeah. I say you let those, we teach a lot of skills in palliative care, and it's almost funny, like you got to be silent. You have to say, I wish statements, I concern. It's like a list. So I said, that's when you love your attendings who taught you, because when you feel it and it's a love match between you and a patient, it is effortless and it's beautiful. But you got to be able to do it when you do not feel it. And that's why you go to fellowship and learn those communication skills, not for the magical lock and key, celestial experience you might have with a patient who you are mirrored with. It's the time where you don't feel it. You don't feel empathy. You may not even like the person, but you still have to do that for that person. And how are you going to do it? Those are the skills you're going to use to deliver the care that is equitable.
Hmm. And that's so beautiful. And this is exactly the point I think that I kind of started out with, is that before we don't need to look at the numbers and try to focus on how do we make our percentage of patients who are people of color, how do we improve that? That's not where we begin. Each one of us starts where we are. We look at our own triggers, we look at our own emotions that arise. Where have we had difficulties with certain patients before? Where have we known like that didn't go as well as I wanted, and why? And look at that. That's how we start. But then we go even deeper and look at how did the system get screwy based on all of these assumptions that I'm feeling inside of me? How is the system making all of this worse?
You're absolutely right. Instead of asking how can we diversify and get more Black patients or Asian patients or whoever the demographic that you're targeting, the question is, how do we make our services more attractive and more helpful? Because people will go to things that are helpful. They will not if you are helpful, they will not bypass you. So start first with the internal fixes. Start first with your structure. And the things that hold up not only attitudes and the biases, but also the structural barriers that you have set in place that make what you are offering as a service unappealing to this population, and then work to dismantle that and change that. And then they will come. Why wouldn't they come?
Because then you actually are removing some of the barriers to people coming.
Yeah. It doesn't start out there. It doesn't start with the liaison going to get patients. It starts with you. If you would, I think this is good business. If you were, nobody sells stuff people don't want and they get angry with them and try to push it on them. No, you've been to what your customer is asking you for. You've been to what the market is asking you for. It's very simple. It's always been there.
That's such good advice, and it's a perfect way for us to finish up our conversation. This has been wonderful, Kim. I want to thank you so much for sharing this information, and it's really touching to me and also tells me some things I need to do to look at within myself. And I'm really happy we've been able to share it with the audience.
Thank you so much for having me, and thank you for giving me this space to speak freely. So I do appreciate it.
Yeah, it's been wonderful. I hope we stay in touch because I'd love to talk with you again sometime. And you're a wealth of wisdom, and it's beautiful. So thank you.
Thank you. I appreciate that.
I hope you enjoyed that conversation with Dr. Kimberly Curseen, and that you will take this opportunity to check yourself, to look within and discover if you are carrying around any implicit biases that you could do a little work on. Hopefully, I think we all need to do that work. So I'll be back again next week with another interview. And until then, take care.